postmenopause special with Halle Berry. The story with Halle Berry was she went to see her GP and they diagnosed her with genital herpes, but she was in perimenopause. Oh. And with Oprah was having heart palpitations. So here is this multi-billionaire and she went through several specialists. I don't know if she had an angiogram or they were close to giving her one. And it was something like 7 specialists and they were like, I think you're actually in perimenopause.
Can we just acknowledge that someone with all the money in the world still can't get the results that they need to get, and they can go to every specialist? How is a normal person meant to figure it out?
Hello and welcome to The Powerful Project. Today we are talking again with Shiree Walker. It's so great to have you back. Welcome back. She is a nurse practitioner and the owner-director of both Yoni Health Clinic, which is a women's health clinic in Perth, and also Glow Aesthetics. What have you been up to, Shiree, since we last talked?
What haven't I been up to? Building on both practices. The Yoni Health Clinic is quite busy now. I'm probably booked out a little bit, a couple of months in advance. So I'm looking at hopefully bringing on another nurse practitioner candidate soon so we can continue to see clients. And I guess we've also expanded, not just seeing women, we're seeing, I guess we've never just been women. Our special interest is women, but I've got a lot of clients asking if their partners and husbands can come in. So, so that's great as well. So,
Awesome. It's good to see that women are not just putting themselves out there, but also acknowledging that maybe their partners need work or help as well. Because I think it's always easy for us to be like, this must be a problem with me, but actually it could be both.
Yeah, and I think when they begin to feel a bit better and they're like, they're struggling a little bit. So, men can be quite stubborn when it comes to, getting health advice. So it's nice. It's got quite a few clients coming along with their partners, or the partners coming separately, just being really open because my assessments are very to the point. We don't leave anything like unquestioned or unturned. So it's really,
Awesome.
Loving it. Yeah.
So what sort of services do you have available now at Yoni Health Clinic?
So initially doing like the full health assessment, which I guess we're not a primary health clinic, but we will go there if need be. So our assessments include looking at, like gut health, mental health, childhood illnesses, and then especially in women, looking at your hormone profile, period or menstrual history. So we go through everything. And then based off that, we do testing according to what is needed. And then from that will be I don't want to say customised plan, but it's an individual plan. So not everything is cookie cutter, like it's specific to what that person needs. And I guess we're getting more resources and referring out as well, as our knowledge base is expanding and our contacts are expanding as well. And that gives someone a whole treatment plan, not just like, here's some maybe medications or supplements, but we're looking at the whole lifestyle and physical and mental factors as well that is important for health and good health.
That's great. And it's so exciting. This has been in the works for a very long time, so it's so exciting to actually see it turn into real life.
Yep, definitely. Everyone's coming along for the ride, so that's,
Have you seen any common, I don't want to call them issues, but I'm missing the vocabulary.
Yeah.
But have you seen any common things that across the board that come up all the time?
I think a lot of the things, I guess I'm getting a variety of ages as well. Like I've had 18-year-olds all the way up to I think the eldest lady I've seen recently I've had 2 in their 70s.
Wow.
Like mid-70s. So it's a big range, but I'm probably getting the mid, like perimenopausal, menopausal clients. So I think my top things I see are brain fog, low energy, mood changes and weight gain. Those are probably my top ones that I'm seeing, and there can be so many factors that can contribute to that and can be dismissed by certain health professionals. So a lot of the clients are just like, I just need help. I just want to feel well. So, I think those are probably my top ones that I'm seeing. Yeah.
Brilliant. That actually ties beautifully into what we really want to talk about today. So we brought you back on again because last time we were chatting, you have so much information, knowledge and skill set. But one that we got quite into was discussing perimenopause and leading into menopause and how it is often a gap in the healthcare world that is there to support women. And you have already mentioned that a lot of the women coming to see you are at that stage of life and really needing help and support. So first of all, what is perimenopause?
So if we take the next step, so we look at menopause.
Yep.
So menopause really is just one day.
Yeah.
So menopause is, the definition is not having a period for 12 months, right? So that's it. That's what who knows who created that definition and whether it's going to change in the future, because as we're evolving a bit more in perimenopause, menopause care, but that's essentially what menopause is. So perimenopause is the period leading up to it, which can be up to 10 years prior. So that is an interesting time for anyone going through it, because the symptoms can really vary between everyone and it can fluctuate a lot. Some might have no symptoms, might have a lot of symptoms, but I find it interesting. It's a lot about putting the jigsaw pieces together, because I think perimenopause, you can't really diagnose it. Blood tests won't really show it. It's more going on symptoms, and the symptoms often overlap with other health processes or disease processes. So that's perimenopause. But the things I guess I say to clients is, and I think people get fearful of it because they're like, what is this? But my brain, when it comes to healthcare, is very simple, and I explain it to my clients, where it's an evolutionary process. That's what it is. It's the time when we, I guess, are not able to reproduce. That's what it is. The only difference is, like many years ago, we were living shorter periods of time. So you would stop reproducing, you would be like the matriarch of the family, and then you might pass away. But now we're living longer. You might say, for example, get to menopause at 50 or around your 50s. You might live for another 30, 40, 50 years. So that is when the perimenopause, your premenopause, looking at the symptoms, and then your menopause also looking at your aftercare when you've had that, one day when your period is the date there, when it just stops. So I think what clients find difficult is actually getting a diagnosis or getting the right treatment to help them during perimenopause.
And so you mentioned a couple of the main symptoms.
Yes.
Can you just repeat them again? So brain fog?
The main ones I see, but there's many.
Is see, and then the other ones.
Yeah, like brain fog, low energy, weight gain. What's the fourth one in my perimenopause brain? Forget what that. But really, you could almost start from head to toe and talk about, because it can be weird things. It can be start from the top, like brain fog in your ears. You can get tinnitus, itchy feeling in the ears, dry eyes. Then you can go down to what we might probably talk a bit more about, joint pain, so frozen shoulder, tummy around the tummy, weight gain, tennis elbow, knee pain, skin crawling. It can be the mood changes, like low mood. It can vaginal dryness. It can be a real dry skin. It's a real range of products. It's a real range of symptoms that I guess it's the jigsaw pieces that we don't put together because you just don't even correlate it. And then I tell clients and they kind of go, oh yeah, and they go, oh yep, that's been happening, and then that's been happening, and then they go, okay, yeah. So nothing to fear. It's just an evolutionary change in us, because that's the way we are. But the symptoms can be
very broad.
Yeah.
And I think one of the ones I've heard of from my clients is about also hot flushes.
Hot flushes, yeah.
What causes that as well?
So hot flushes is probably the one that we hear. Hot flushes and mood swings, right? I'm a crazy, I'm going to you. Those are probably the ones when we associate with menopause. And that's because I guess what you call your thermoregulation system in your body is a bit out of whack. So we call those your vasomotor symptoms, like sweating, and it's usually at night. But the main cause of it is because your estrogen levels are dropping. Estrogen is probably the main part of it. Estrogen, I think they're still finding it's what estrogen does in the body, but it's part of over 300 processes in the body. So that's why and that's probably increasing as there's more research, going into the space for perimenopause, menopause. So we're finding more symptoms as we go along that we contribute to the loss of estrogen. But it also is hormones your progesterone tanks, testosterone tanks. There's a lot of other hormones in the hormone cascade that kind of go down, but hot flushes seem to be the one. But once we look at restoring hormones, that's when the symptoms kind of can settle. There's often also non-hormonal medications that people can use as well, say for if they can't take hormone medication, there are, and then are newer ones on the market. I had a client who had estrogen positive breast cancer in the past, and so was having, the perimenopausal, menopausal symptoms, so couldn't take And that's a whole other topic about hormone replacement therapy and breast cancer and things like that. But there's medications on the market that will non-hormone related that can help those vasomotor symptoms as well. So there's other things that we can do.
So you have a huge toolkit of knowledge both from medical world and your work with the naturopath that you were doing work with?
Yeah. So working in a functional medicine clinic.
Yeah, functional medicine clinic. So you've got both sides with a huge toolkit of what you can use to help people of all different backgrounds to help them with this stage of life.
Yeah, and the path they want to go down. Some people want to go more natural and see how they go, and we'll just work with what they want to do. But still, as a health professional, I guess I need to make sure that they're safe in our process and the way that we're going to work with them. So,
What is your opinion on hormone replacement therapy?
It's great.
Yeah?
It's great. And I went to Sydney and I did a 3-day workshop on hormone prescribing, advanced hormone prescribing. And the best thing that they said is we shouldn't really call it hormone replacement. It should be called hormone restoration because we're restoring what was there. So I think that's the wording we need to maybe change. Yeah.
Because I've had this conversation with my mom and I was like, maybe you need to do it. And she's like, I don't want to have any hormones. And I'm like, it's different to the pill though.
Yes,
I think that's because everyone's now jumping off the pill and jumping off hormones, quote unquote.
Yeah.
But then in the age range where it might make sense, then people get afraid or scared because maybe it is you shouldn't be taking any artificial hormones or So that's why I've asked.
And the best way to think about it, and I explain to people, is we have synthetic hormones, which is your contraceptive pills, and then we have body identical or bioidentical hormones, which is what is created, which are still technically created in a lab or a biopharmaceutical, but they are identical to what's in the body. So that's the difference that I think people need to know about. So really, the way we need to think about things like the oral contraceptive, and I'm not against it because there are some women who are on it into menopause because it helps their symptoms. But I do like to explain to them it's not giving you the benefits of being on body identical hormones. But it might be symptom control, like those, hot sweats and mood swings and things like that. But your oral contraceptive pill is technically, so in younger women, shutting off your ovaries. So do we consider that like a drug-induced menopause? So, I know that there was a study that came out where it was looking at teenagers who've been on the pill from, from their teen years and then bone mineral density issues because they've been on it for a long period of time. So I guess the conversation's changing, not just in perimenopause, menopausal women, but across the range. So I think it's that education and learning about the differences in synthetic hormones versus body identical hormones and what's mimicking what's in the body, and that's I think is where we need to have a lot more education for women and have resources for them or health professionals where they can ask the questions and feel satisfied with the answers.
I tried to explain to her with my very minimal knowledge the podcasts and the books I've read, and I was like, I think it's different. Yeah. But now that I've heard it from a professional, she's like, I don't know if I can listen to the podcast in English and understand it all. I'm like, well, I can translate it.
Perfect. Yeah.
Word for word.
Yeah.
So it's good.
Yeah.
Thank you.
Yeah. No worries.
Yeah, and I think that's exactly the support people need because you get ideas or you get old wives' tales from others.
A lot of misinformation.
Yeah, I've only done a little bit of research into it because it is now affecting some of my clients.
Yeah.
And then they have questions. I was like, I think that you need to ask this to someone else because I'm far away from qualified and I'm also a bit of a placebo because I'm still far away.
Yeah.
So I don't know what you're going through, but the topic is definitely rising and there's so much and so little out there.
Yeah.
So much confusing information and then also still so little research because I think, I'm going to say quote unquote, the trend has only picked up in the last few years.
Thanks to us Gen Xers. We're not laying down. We're not doing our mother's menopause. We're
not laying down.
And I think it's a great thing that we're talking about it and talking about it openly, and people's family members and their partners are coming along and being like, and like someone sent me a meme the other day about, oh, I was sent this question by someone's husband, like, what should I do in my, like, my wife's in like perimenopause, menopause, and it was like, don't chew loudly. If I asked him, it was like, like all the things, and it's like going, yeah, like just kind of know what's going on, and it can change day to day, and we ain't in control of it. Like it's happening. So I think having conversations is amazing. Yeah.
With support.
With support, yes, yeah.
What do you find in like people with relationships that come back and the husbands struggle with, or what are like some tips or communication starters for a woman that might go through perimenopause? Because I think it's easy to be like, oh yeah, you're on your period all the time.
Yeah.
That's what people say, like, oh, she must be on her period when she's moody.
Yeah.
But it isn't quite like that.
No. And I think it's, and the more research, and you would see this as well, is like, when it comes to exercise, we're not mini men.
No.
We can't train. We shouldn't be training like what the status quo is for men. We train differently during our cycle because the hormones fluctuate. In perimenopause, those hormones are fluctuating even more because we're the ovaries are just beginning to kind of like peter out. And so other hormones are like trying to make it go quicker. So that's just like, so women's periods might become like, or their cycles might become longer, or they might become shorter. They might start flooding when they have their periods. So which means hormones are going up and down. They're going crazy. They're quicker to anger. Like I've had some clients go, I was like yelling at the kids and I can't like control it, or yelling at the husband, or them husband chewing, chewing, you're like annoyed.
Chewing too loud.
Or, things like changes in sex drive, vaginal dryness, all this type of stuff. So I think it's partners and family members need to understand it and support, because there is like the flip side of the mood side of things with women as well. I haven't seen so much of the research here, but, listening to some of the doctors from overseas who are big in the like, menopause or perimenopause space, talking, like I know in the UK, like a lot of women in that age range quitting their jobs because they can't function at that level. Low mood, one of the...
Focus and attention.
Yeah, focus and attention. So high-flying jobs and then have to quit because they
Crazy.
And one of the medical conferences that was on that I did, I listened to like the replay of it because it was in Sydney. One of the speakers, the doctors, was talking about someone in the UK who had committed suicide from like the low mood, because that can happen as well. And it actually made me she got teary when she was talking about it, but it made me reflect on it. When I first graduated, I worked at the big mental health hospital here in WA. That was my first rotation. And I remember we had a lady who probably would have been in her 40s came in and really, really low mood. And I remember she had like this really flat, what we call like an affect, like there was just like nothing behind there. She was going for electroconvulsive therapy. So it was the first time I'd ever seen that. It's like, I think I was like a 20-year-old. And I think back now after listening to that doctor talk, and I kind of go, I wonder if that's what was happening. Like she was in perimenopause, menopause. So that was like 25 years ago.
Did she have no other like underlying
No,
factors
she was
going on
fine.
at all?
From all accounts, and what I remember was like a happy mum with like youngish
wow.
teenage children, and she was in the no self-harm, but we were in like the assessment unit, but a locked ward, so like under like close supervision. So it makes me kind of go back and think, okay, we need to do better.
You didn't have any knowledge or awareness that this could happen, or that these symptoms might be something you need to start looking out for at that age, like mid-40s, early 50s, or even earlier actually, and people don't know. They might think that they're spiralling into a mental breakdown or depression or something else because they've got no skills, no awareness and no help. So you could see why that might spiral, especially if someone was experiencing lots of different symptoms. Yeah, that's really...
And I think, that part we're talking about partners, then not just partners, but, changes in relationship because your mood is changing. So how you're interacting, partners, family members, children, work colleagues, all that changes as well. So I think, I've started asking more since listening to that webinar, that conference is... I always ask about mood changes and mental health, but I'm asking like a little bit more, and I'm even delving a bit more into their previous history of, what about if you've had children, any history of postnatal depression. I'll often find women who are like, oh yeah, I think I definitely had it with my first one, but there was nothing diagnosed. But with my second one, yes, it was diagnosed and I went on medication and things like that. So, and I don't, is there a link between if they've had it in, postnatal depression? Is there going to be something more? They might be more prone to the mood changes when they're going through perimenopause, menopause. So I think that's an important factor. And for them to be seen and heard as well. So,
I think that's so important.
Much to it.
Yeah. Yeah.
And I mean, hopefully, obviously getting help from somebody like you means that the symptoms may lessen, or you're able to regulate and manage a little better, or have better skill set to deal and regulate in your life.
Yeah.
Have you seen that being the case?
Yeah, I think same again. You're being seen and heard, and then being like told, okay, this is normal, and this
What
can
to
happen.
expect,
And
maybe.
and once we start doing an assessment and maybe putting a treatment plan in place, people begin to feel better. And I think it's also about using the tools. So maybe they do need to go on antidepressants. Like, it shouldn't be shunned. It's part of the tools that we're using. So, or if they are on it, sometimes they want to rush off it because now they're getting their hormones looked at. I said, no, it's all part of the process. Like, let's put everything in place and not rush to get there, because like I said, this could be the next 20, 30 years of your life if you live that long. So yeah, it's the journey that we're kind of taking. Yeah.
And you said that menopause is one day,
Yeah.
but that technically these symptoms or things can continue on. Is there any certain point where the hormones have kind of flatlined and it's flat? Or is that
Technically that day
is
when
the
you're
flat day.
no
Okay,
periods
yeah.
of like for 12 months.
Yeah.
It's probably before that, because you're probably, that's just the medical definition of you're in menopause. You're gone from
Yeah.
perimenopause to menopause. But
Yeah.
that's when it kind of
So that's when it
flatlines.
technically flatlines.
Yeah. Unless, I guess, we're looking at hormone restoration therapy.
Yeah.
And then we're supporting the body that way. But yeah.
Yeah. Oh, that's so interesting to know. And I actually did not know that about menopause being one singular.
That's just the
time.
definition.
That's the definition.
Yeah. So 12 months without a period.
Yeah, that's fascinating.
Yeah.
And so what other ways might this affect a woman in her life? So we've talked a little bit about kind of symptoms that may notice. Like, one common question that V got was about conditions like frozen shoulder. So is there any underlying reason why that might be a little bit more common in women who are going through perimenopause?
Yeah. So the main reason that can happen, and other, I guess, physical symptoms, is the drop in estrogen. So estrogen has a very potent anti-inflammatory effect in the body. So I've put notes here because I wanted to get this right in my wording. So if you have a drop in estrogen in the body, that can increase inflammation. It can increase visceral adiposity. So, we get that weight gain around the weights and the thighs and the bottom.
So that's why people tend to notice a little bit more maybe abdominal fat. At this age
Yeah,
as
and
well.
they'll say, I've changed nothing, I'm still eating well and I'm still exercising, and it's just like creeping up. So that is the estrogen fluctuations. So drop in estrogen can also mean a decrease in bone mineral density and decrease in muscle mass and strength. This is now when we begin to, I guess, the symptoms begin to creep in, and what you might see as well is the things like, arthralgia, so like joint pain without any quote unquote actual diagnosed disease. Frozen shoulder is one of them, fibromyalgia, rheumatoid arthritis, but it can be things like, like tennis elbow, meniscal pain, arthritis-like symptoms, hip bursitis, lower back pain. Yeah, it can be like a range of physical symptoms, which you're like, I just woke up and I haven't done anything out of like the ordinary, but I'm sore, which I guess for you guys then can affect if someone's coming to see you, or not wanting to push through the pain, or not knowing the reasons why and thinking they are injured when it might be more from an inflammatory process that's happening in the body from those hormone fluctuations.
Yeah, and that's so interesting that you're listing a lot of those things that are turning up. A lot of my perimenopausal or menopausal clients will have at least one of those things on that list from their life. And because they haven't been exercising or supporting their body up to that point, it's kind of declined so rapidly. That's what's made them come in. But strength training has been one of the best things to incorporate to help with things like the bone mineral density and also supporting the joints, I've noticed, which is amazing. But it's so fascinating that it could be very, very directly linked. It's not just the fact that maybe you're just injured one day, because a lot of them haven't said, I haven't done anything. I don't understand why I've got bursitis all of a sudden.
Or they're thinking maybe the increase in exercise is contributing to like joint pain. And so they're like, maybe I don't need to, I'm not coming in for a session because,
Well, most of the time they do see benefits, which is great. So that's the benefit part.
And I think that's an important part. And I think and most of my clients, once we get them on hormone restoration, are like, oh my God, like I feel amazing. Like I'm
like a
back
new
in the gym and I'm doing, like I'm exercising and I'm like my weights are going up. So that it's not just, I guess, estrogen benefits as well. There's things like, testosterone and progesterone. So testosterone, we often think of testosterone as only in men. When you think about when we talk about like training through your cycle, your testosterone kind of surges when you've through ovulation. So you'll probably see, we talk about like clients might hit their PBs like in that part of their face as well. It's likely because of the testosterone surging. So that's an important part because testosterone is important for the bone, also for muscle growth and protein synthesis. So that's an important, and in metabolism as well. So the tummy fat that's happening as well, so that's important. And then progesterone, also collagen production in the joints as well. It's not just estrogen, and there's a few other ones I haven't spoken about, but that might be the other things to consider when we're looking at hormone restoration, when it's looking at the whole musculoskeletal system.
It's all one big cycle and everything. It's like chicken or egg, what's affecting what. No?
Yeah, exactly. And the other thing I was going to say, so this is something that I learned recently from listening to that conference, which I found the geek part in me.
I love it.
So, and then, we always think about, I guess, bone mineral density. We see the little old ladies, with the hunchback, and they've got osteoarthritis and osteoporosis. So we kind of think about that. But that has your direct link to perimenopause, menopause, and the changes in the bone because, like your estrogen levels are decreasing. But there are these stem cells, so MSC, I'm going to try and pronounce it properly, mesenchymal stem cells, that are adult stem cells found in various tissues in the body, mainly like in the bone marrow, and they differentiate into a variety of cell types. So the ones they look at, so osteoblasts, which help with bone, chondrocytes for cartilage, myoblasts for muscles, tenoblasts for tendons, stromal fibroblasts for stroma, and pre-adipocytes for adipose. So that's your whole musculoskeletal symptom. So and that's what your musculoskeletal tissue is derived from. So it's really, we need to start thinking about bones and muscles as more part of the endocrine system because really there's still this hormonal cascade that's happening. So, part of that was like your bone have this, so your hormones is osteocalcin, which works on the brain to build nerve cells. Muscles, irisin works on bone and talks to fat, and adipose is leptin. So the whole system is talking to each other, and it's this muscle cascade. So it's like this, like joint pain, which can happen from the hormones, but this endocrine system for the musculoskeletal system, I think is, and I'm throwing back to you guys and what you do and in your profession, we need to be exercising correctly to be able to keep those muscles and bones strong as well. So it all kind of, So basically, need to lift heavy shit.
Yeah.
So basically,
That's what it comes back to.
Yeah.
So basically, one of the biggest tools that you would give outside of everything you do is get them into the gym and training.
Yeah.
Is there any other support or, I guess, other options that a woman that is experiencing any of it should do? Because I know sleep issues can be another massive impact as well.
So I think that also comes down to looking at hormones. So I like to investigate in clients what the cortisol levels are doing. So same again, I'm a very basic bitch when it comes to when it's looking at what the body and the evolutionary process is. So we are either in fight or flight, rest and digest. So we've got cortisol levels which should gently rise in the morning when we wake up, stabilise throughout the day, drop off in the evening, and then your melatonin. So melatonin is also a hormone, should slowly rise in the evening, and then cortisol levels should be coming down, melatonin, you should be getting good sleep. But if you're in stressful jobs, you're busy, you're on the go, you've got unresolved trauma, cortisol levels can be high, melatonin levels are going to drop down, you're not going to sleep. So that can even be without perimenopause, menopause. But when hormones are fluctuating, progesterone is really important in women. Progesterone is very calming, relaxing, our chill pill. So when those are fluctuating, we're not going to get good sleep as well. So, of course, good sleep, you're not going to want to get up in the morning and relax. So sometimes maybe getting into the gym might be a long-term goal. Maybe we need to do the more calming stuff. Maybe it needs to be like yoga or Pilates or, meditation, deep breathing exercises to regulate their nervous system before we then, progress them onto then being in the gym. So it really is, looking at the whole person and the whole lifestyle and what's happening. And this is where, going back to partners and relationships, like, I need you to pick up more of this load. And I guess the things that women don't do well is asking for or not asking, saying what they need done. Because that's the way we're conditioned to be like, could you please, and can you? So I need this from you. And also, like, you do get to that age where you're just like, not friendships fall away, but you're not contributing to me positively in my life, and I just don't have I don't have the
Capacity,
space
yeah.
for you. Yeah,
Yeah.
yeah, yeah. So I think it might be, if the sleep is not great, we might need to look at the cortisol levels. We might need to do some work on that. Sometimes hormones, just going on hormone restoration is what actually will help that. Or like I said, like adjusting what type of exercise they're doing. Maybe they need to start walking, get those steps in, get that happening, and then we build up to going to the gym and
And adding in the resistance, because
Yep.
the resistance is what's going to offset the bone mineral
yeah.
problem or the bone mineral density loss, and
Yeah.
also the sarcopenia of muscle mass
Yeah.
decrease, which does drop off very rapidly.
Yeah.
I think it's actually mid-30s that it drops off anyway, and
Yeah.
then when perimenopause, it's going to drop off even faster.
Yeah.
So I think a lot of women don't realise that if they weren't training earlier, they might not have noticed the biggest difference between someone who was exercising and someone who wasn't, because there wasn't so much of a discrepancy. But as that declines, you'll notice that the gap gets bigger and bigger and bigger. And my biggest thing, and our biggest motivation, actually, we want to be strong grandmas.
Yeah.
I
is
always
just
say that.
the difference in someone's capability, both physically and mentally, when they have been exercising or resistance training in some way, or load bearing their body.
Yeah.
Even things like daily activity, moving up steps and
Yep.
being active
Yeah.
when they're older is huge, and their functionality to the end of their life is
Yeah.
incredible. So quality of life starts from this age.
And that's
going
that
up
thing,
from there.
that's going to, keep you living independently longer, and also, out of nursing homes, because, having worked in the hospital for like 2 decades, it's the things we see, someone who's had a fall, and like often the hip fracture is like the end of
Yeah.
it for a lot of people. So, just trying to hopefully prevent falls, but healthier bones. If you do potentially have a fall, if you haven't broken something, being able to get up off the floor in older age, you're not laying on the floor until someone comes to find you, however many hours of the next day. So those, I think, are all important. And the data shows we don't really slow down until 70. So it's not like I'm in my 30s, 40s and I've left it too late.
Never too late.
Never too late. Never too late. So.
And also, if that isn't enough motivation, there was a recent statistic how our population is just going to get older.
Yep.
So if you're not looking after your body now, there will be less nurses and caretakers actually going to be able to look after you as you age, because our generation just gets older, and unless there's going to be AI robots taking care of you,
Yep.
you're going to be we're going to be in trouble.
Yeah.
Because we have to have our own back kind of thing.
Yeah, exactly. And I think, it is, research and technology is moving faster, so we are getting more information and resources there for people to be able to be like, okay, I can start to take these steps to look after my health or my longevity. And that's what I guess my clinic is. It's not just hormones. I like to call it longevity medicine, because it's about being healthier, so you're able to, live longer, but live, healthier
Live better.
and more independent. So,
Yeah, increasing that quality of life and feeling good within
Yep.
your body,
Yep.
because that's so possible. And do you find that's probably the biggest thing that blocks women is the lack of knowledge, first of all, and the misinformation. But then you mentioned that saying they need help and knowing they need help. So at what point do you notice that a lot of women finally come to you? What's kind of been the turning point?
I guess a lot of the time is maybe they have already, probably 2 things. They've seen their primary healthcare physician and mentioned symptoms, and they either get brushed off because they're still like this, oh, well, that's to be expected, like you're in your perimenopause, menopausal, just deal with it. Or, it might be the weight loss thing where it's like, eat less and exercise more. It's like, I have been doing that.
And actually, a lot of women at this age have been eating less and less and less, even under their basal metabolic rate, which is the amount of energy they need per day to just exist at rest. And they're noticing no fat loss and no improvement in energy, of course, because they've got no food. And that can be the most frustrating thing ever, to be told to just eat less and move more, when there should be way more support around that to help them.
And then for me, like I said, it's not my area of expertise, but what's that doing to their bone and muscle when they've been underfeeding
it's
themselves?
not helping them at all. And increasing their chances of injury from the movement, because they're not fueling enough, because they're frustrated that they're not seeing the fat loss improvements, when there could be more underlying factors that do need to be addressed. Of course, the energy principle still applies. Yes, if we do need to lose body fat in the long run, it's about that energy intake, but so often at that age, it starts to become a hormonal problem, and also what's going on in that cascade, like you mentioned. And at least with understanding and support and knowledge, could be also more acceptance that, yes, maybe I'll still be experiencing some symptoms, I might still struggle a little bit more, but there's so much I can still do to feel great and to actually accept this phase of life or this chapter,
Yeah.
which I think is so exciting. I'm really grateful that you're out there doing this because I do believe women so need the support.
Yeah.
And when I get clients that come in that are experiencing these struggles, I really feel for them and want to give them somewhere to go. So it's good that you're here now.
Thank you.
Cycling back to other symptoms that people struggle
Yes.
with, one of the ones that was also mentioned in our questions was about hair loss. So there's a cascade going on with like internal symptoms. There's been physical, like muscle, bone, tendon symptoms, but also hair loss and also aesthetic stuff people struggle with too, because I know it can be a big problem, like when you're starting to notice these symptoms that are frustrating. So what do you know what causes that side of things?
So when it comes to hair loss, this is when I also like to look at baseline level blood tests with women as well, because a lot of the time we are just pushing through. We can have these symptoms for a really long period of time. So I like to look at like hormones, obviously, but like vitamin D, iron, ferritin levels, B12, those are really important. Obviously, like low iron levels can cause like hair loss as well. Low B12 can. Then I want to look at thyroid function as well. So thyroid is also part of the endocrine system. So when your thyroid is off, that can cause like a lot of hair loss, hair shedding, change in the hormones. You know, like when women have had like babies, they can get that postpartum like shedding. So all part of this hormone cascade as well. So then also sometimes by looking at that and addressing those things, or hormone restoration, or if we need thyroid, because thyroid also is thyroid stimulating hormone. There's other hormones that come under the thyroid, but that is all part of the hormone cascade, and so that can change as well for women. So it's looking at that. And then also, I guess part of that kind of leads on to the aesthetic changes, because we have these changes in collagen and elastin in the body as well. So that skin and hair is all part of that cascade as well. So I guess the aesthetic changes that can happen is because we start to lose collagen production, like decreases from when we get to our like mid-30s, and then once you get to perimenopause, I think it drops by something like 30% again, and then each year after that it drops by a percentage. So this is when we can see a lot of physical changes, probably more so in our face, in our body, but in our face, because that's what we're looking at every day in the mirror. And so that can be changes in the skin, so like dryness in the skin, more fine lines and wrinkles, sagging in the skin. Those are probably the main things that I see that clients kind of discuss as well. Or the skin just being really dry. They're like, no matter how much I put on, it's just like, not getting hydrated. So those changes can happen as well. And then I guess it just depends on what clients want to do. So sometimes it is just like, are we just putting them on like the hormone restoration? That might help. Are we going down the line of skin treatments? Are we going down the line of aesthetics? I think it's not as taboo to be able to be like, well, we can look at all these things.
What's great is you have the skill set in that area too. So there's nothing wrong with validating almost the vanity side of this too. Like when you're losing these changes are happening so rapidly, there's nothing wrong with doing anything that you are comfortable doing to help feel great at that stage and age of life on both sides. Yeah. So I think that's awesome that you've got so many options and solutions.
Yeah. I think it works well. It just gives people other options and to feel open to chat, have a discussion about it.
With the mood changes as well, do you notice like a lack of confidence or like a drop in confidence and self-belief? Is that part of like something that you notice?
I think with some clients, because they get that brain fog and then they're like, oh my God, like, I can't remember what I'm meant to be doing, or they might be at work and forget details and things like that. So I think that can make that drop in confidence. And so once we kind of work on that, and like I said, that could be that whole, because when we're looking at estrogen restoration in the body, the main things we talk about and the research talks about is like the protective factors on the brain, cardiac, protection, bone health as well. Those are probably the main things, but obviously there's lots of other ones. But so sometimes by restoring the estrogen levels can also help. But that stress management, getting good sleep, getting the melatonin, getting cortisol levels down, all that, I think, you know what it's like when you've had a crap sleep and then like I just can't function. Like, and then when people do the cascade of like, give me a coffee, I need the caffeine. So going back to like basic, knowledge of the body is caffeine is a stimulant. It's going to put your body into that fight or flight mode because you're ramping it up with the stimulant. So then that becomes this cascade and people get on like a lot of them like, oh, I can't do anything before my coffee in the morning. It's like, maybe you should look at addressing the reason why you need a coffee as a stimulant to get you up and going in the morning. So, yeah. it's interesting. Yeah.
Yeah, it's probably very interesting that it has such a effect on the brain, but then also secondarily, the second guessing or the lack of confidence that starts happening because of this. And again, I think it ties straight back into a lack of education. If you don't know what's going on, it'll be terrifying.
Yeah.
Yeah.
It's like,
feel
what
like
the
you're
heck is
losing-
wrong with me, blah, blah, blah.
Yeah, I feel like you're losing yourself and who you are and your ability to function, like you mentioned about the women in their jobs and like especially high jobs with high levels of need every day to actually perform, and then all of a sudden they don't have everything that they used to rely on. So it can be very scary.
And it makes me think about, going back, nursing profession, like it's a female dominated
Yeah.
industry. And I think I kind of go, we're doing shift work.
Yeah, so you already have
Yep.
issues.
We're taking on, it's a stressful job.
Very stressful.
You're dealing with like, physically stressful, emotionally stressful, mentally stressful. I'm like, and it's one of those jobs where a lot of nurses do work like into their like 60s, 70s or, and I kind of go, no, I wonder what's happening there. And I kind of have been going, I wonder if I should be like having special packages for like
For nurses.
nurses. Yeah, because I just went, we're the caregivers. Who's looking after us? And it's probably something that's it's just not talked about. Like you'll see someone fanning themselves with a hot flush. Oh yeah, ha ha ha, having a hot flush. But there's no, as more research is coming around about how shift work can impact like your longevity.
Yeah.
Someone's got to do the job, but how do we support people through that as well? So yeah.
And you've seen it from many different angles with all the areas you've worked at in nursing as well.
Yeah.
There's just so much going on, but also you're right, the primary caregivers of people who need it the most.
Yeah.
Yeah.
And who looks after them.
Yeah. Yeah. Absolutely. So yeah.
Yeah, nurses care package and Yoni Health.
Yeah. Coming soon.
Use discount code.
Yeah.
It's funny when they tell you to niche down in a business, like what would be a good niche down actually.
I just, it's just, I guess you just see clients and people and they can't get off that roller coaster. And I think not just nurses, probably like mums as well. Mm-hmm. They're on that train and they're just like, can't get off it because I have to like get up and get the kids ready and I have to need to do this and then I've got to go to work and I've got to come home and pick them up and the kids have got sport and I've got to get dinner ready and there's no where, and like it's that crossover as well as like a lot of perimenopausal, menopausal women, I guess depending on what age have had their children, but maybe when the kids are like maybe because you've got teenagers and perimenopausal women in the house.
Combination.
Yeah.
It's a lot.
Yeah, it's a lot. But maybe that's that time when they have less dependent people on them so they can take that step back. But they've been on that roller coaster for like 10, 15 years and now they're like, so now you're having to unravel 10, 15 years of issues. So same again, going back to the basics, if their body's been in a fight or flight mode for like 10, 15 years, we've got some work to do. And I think it's allowing them the space to be able to work on themselves is important as well, which I feel like sometimes going to a primary healthcare practitioner, they might not get the appointments are a lot shorter and they might not feel heard or that practitioner just might not have the time or the capacity to be like, I can see you're struggling and we need to like, go through a lot more, but they don't have the time and that capacity, or they don't have the training because it's not something that as healthcare professionals we get trained in unless it becomes your area of interest or you've been through it yourself. So it's like I said, not blaming other healthcare practitioners, but unless you have been through it yourself or maybe you have a loved one who's been through it and you're like, I've researched this and and so there are some people who I have a few clients who come to see me and they're like, oh yeah, I've told my doctor that I'm seeing you and they're so happy that I've gone to see like a women's health because my initial consults are an hour. And so we cover a lot of stuff in there, and then my follow-ups are 45 minutes. So it's a different care model. Yeah.
Topic. Like we've just talked about so many areas that are affected. You can't possibly do that in 10 minutes.
No. And I think there are more healthcare practitioners and primary healthcare physicians who are taking on. You'll see it's been interesting to see there are a lot more quote unquote menopause clinics coming up, which is great. And so hopefully the access is there for more people, and offering the correct care or correct assessment,
Because there's everything related to perimenopause or menopause as well, private expenses.
So my fee is private, but you can do like some of the testing under Medicare, and you can get a partial Medicare rebate. So
And that's another thing. You already have all these stresses, then you've got the financial stress on top, and where does it stop? Where do I start?
Yeah, and for me, I feel like when you've been doing it a while, you kind of see like that jigsaw pattern, and you kind of be like, yep, this is what I'm thinking, and let's do the testing and see what comes back. So really, I probably want to see people for initial consult to do a full assessment, decide with the client what testing we want to do. Then the next appointment is we look at their results, and I've created a customised plan based on their results, and whatever that might be, whether it's like hormone restoration or supplements or lifestyle changes. And then I probably don't want to see them for a good couple of months. All being well, if we've started them on hormone restoration, we'll probably have them on it for 8 to 10 weeks, do repeat bloods just to see how their body's going, check their symptoms. And then if all is well, I probably don't want to see them for like 6 to 8 months. Initial outlay, and then I guess, money-wise, but then hopefully not having to see them as an ongoing. Clients can if they want, that's more than happy to be there as support for them. But, trying to just spread it out. And then just, I think, seeing them maybe like once a year, then ongoing bloods, make sure things haven't changed, make sure things are going well, and work from that way.
Because for me, it's a no-brainer to drop money on my health, but I know that for a lot of people, that's the first thing to go.
Yeah.
And for me, it's like, well, if you want the longevity and a strong grandma, you kind of have to invest in your health, because that's all you've got left in the end of the day.
Yeah, yeah. And I always the analysis of I don't drink coffee, but how much is a takeaway coffee? What is it?
It's like $7 now.
Yeah, 7, yeah. So 7 times 7, then however many days, kind of go, that could be the money putting aside for for an appointment. So
it's actually really interesting when you do put it like that, though, because say you break down an appointment in one chunk, it may seem like a larger amount of money.
Yeah.
If you divvy it down to how often you'd actually see that healthcare professional, the actual analysis of what's going on and the aftercare that's going to help you, it is actually a no-brainer in regards to finances.
How much is the stress costing you?
How much is the stress costing you?
Unfunctioning and all these other things, and your relationship. It might cost your relationship, or it might cost arguments with your children, or it might cost your job because you are so brain fogged. In that perspective, it's really a no-brainer.
Yeah. And one good thing that's happened as well as of March is there are a couple of hormone replacement therapy medications that are now listed on the PBS. So that's amazing as well. So actually some acknowledgement where we're like, okay, there's an investment in women's health in Australia. And so that also, I guess, helps from that financial burden as well, because once you get to menopause, you're on those hormones every day. So that, yes, does become a bit of financial burden as well. But now that they're on the PBS, then that pricing comes down as well. So that's great. Yeah.
Finally.
Yeah.
Again, the progression of women's health, slow, steady. I'm not sure if it's steady, but it's slow.
Yeah. I mean,
it's moving.
It's moving, and the conversation is opening up. And not just in Australia, I think worldwide. I think Oprah just had another perimenopause, menopause special where Halle Berry and all that was on there. But, they're talking about, I think the story with Halle Berry was she went to see her GP, and I think they diagnosed her with genital herpes.
Oh.
But she was in perimenopause.
Oh my God.
But,
really?
Yeah,
That's wild.
Yep.
That's
And
actually the story?
Yep,
Wow.
and with Oprah, because I've used a snippet when I've given a talk last year on the pathophysiology of perimenopause and menopause. I think Oprah was having heart palpitations. So here is this multi-billionaire, and she went through several specialists. I think they were all, I don't know if she had an angiogram or they were close to giving her one. And then, so I think she went, it was something like 7 specialists, and they were like, I think you're actually in perimenopause.
Can we just acknowledge that someone with all the money in the world still can't get the results that they need to get, and they can go to every specialist they want?
Yeah.
How is a normal person meant to figure it out?
Yeah,
It's crazy.
Exactly. And that's why I think it's great that we are talking about it more, and there's more these clinics like my own, or other ones that are kind of popping up where you're going, I've had a client as well who have been having these heart palpitations and anxiety, also going down that line of, we won't get into it because there's so much, whether she's got late diagnosis ADHD as a grown woman, did her hormones, got her on some hormone replacement therapy, and palpitations have gone.
Wow.
Stopped taking the ADHD medications. So it's, so it's the symptom management and just being let's just see where we're going. But like I said, also not rushing it, not being like, come off everything and we're going to,
Yeah.
like, it's just like, let's just do this in a controlled manner so we're not doing too much,
It's great hearing you do that. You keep going back to the fundamentals, the basics, you zoom out,
Yeah.
and you've got such a detailed analysis when it comes to the symptom picture that you're building when you look at someone. I think probably that might be a little bit of the challenge is unfortunately someone doesn't know where to go, who to talk to. They might go to their GP, who's amazing,
Yeah.
but then they say, oh, you've just got this one symptom you've come in with. I'm going to refer you to this specialist.
Yeah.
Specialist is almost like a hammer that only knows one thing. Everything looks like a nail. So it's
Yeah.
just like, all right, you've got this, and give you the medication for said problem. But they may not, I don't know what they're going through, but
Yeah.
may not have analysed the picture of other things going on. Because like you mentioned, so many things overlap.
Yeah.
And if they don't have the full picture, why would we know what else might be going on?
Yeah.
And sometimes I guess maybe you might be going down that path and thinking, hey, maybe it actually is this problem and that's the specialist you need to go and see.
Yeah. And also, that thing that's hard for us is you can't show perimenopause on bloods.
Yeah, true. There's no stamp.
So I think it becomes that knowledge base that we as health professionals need to do the research and educate ourselves a bit more to be like, yep, we can have blood. And there's this, not controversy, but there's discussion now about, well, do I need to do bloods on someone if I'm talking with them and their symptoms are saying to me they've got perimenopause? Why can't I just start them on? So I think as health professionals, we need to look at I guess what we always look at in healthcare when we're looking at to quote unquote diagnose someone, inclusion and exclusion of other health conditions. I like to do bloods, I guess, because I like the baseline of not just the hormones, but I've said to you, there's a whole range that I do. The other thing, I guess, that it's probably relevant for both our clients is I like to look at blood sugar and insulin levels because insulin resistance is a big thing, especially in perimenopausal women, and that weight gain component and the difficulty in losing weight and that weight that's coming on around the belly. So there's other range of bloods that I like to check as well because we can potentially, with insulin resistance, go into that pre-diabetic range because we have been putting on that weight that's difficult to budge once you get to perimenopause, menopause. And so that also is looking at longevity components because we can reverse, as we know, diet and lifestyle, type 2 diabetes.
Not leading into type 2 diabetes.
Yeah. And so, so it's the bloods, I think, are a good thing to have a baseline. And, you can do it with what's covered under Medicare. It can be once a year, once every 6 months. It's not, quote unquote, an abuse of the Medicare system. We can do what is, got a valid Medicare card, then we can do.
Like abuse of the Medicare system, looking after your health.
Yeah.
So checking in on your health so that you're not a burden in later years.
Exactly. So you can, I like to personally, I like to do the blood so we get a whole picture and see what's happening, and then we know exactly.
And it's something that's within your scope of practice and your ability. So why not use all of that ability to see as much information as possible about the person sitting in front of you.
Exactly.
Yeah, I really like the bigger picture approach. Yeah. It's good.
Yeah. I think it has to be.
Yeah. It just makes sense, but I feel like it's so easy to not do.
Yeah. And I think you're right, about, we can pinpoint, just really pinpoint on one thing, but it's this whole cascade of symptoms because the whole body is being affected. So, we just need to look at that whole person and that whole picture and then create a plan according to what's happening. And then and also for myself, like I said, I'm not an expert in nutrition. I'm not a PT. I know the basics and I know what I can get people started on, and then I'll refer out and make suggestions. And the great thing with technology is there's a lot of things online that people can do, and I probably will find, I'm sure you'll agree, perimenopausal and menopausal women, if we haven't been in the gym for a long time, if ever, it's very scary to go in there. So sometimes I'm like, just start stuff at home. Yeah. Start stuff at home, and then
start your walking and then add the resistance.
Yeah. And then work in, and then and then find a PT that you're comfortable with and you're going to work with, and then you build up from there. So I mean, my ultimate thing, my clinic space as well, is I've got a beautiful room where it's quite big, and I want to build a bit more community and have maybe education sessions in for clients to come in to talk with PTs and just be like, okay, this is how you gently get back into it. So the other thing with heavy lifting is the other thing, when I've been listening to these, my own education is foot speed is an important part of staying healthy and longevity in women as well, because that's helping, I guess, prevent falls as well, and also creating those neural pathways.
And everything
as well.
starts on your feet.
Yeah. Yeah.
every lift, everything is from your feet up.
Yeah. So I think the things I learned from that medical conference was the foot speed, doing your like jumping, because that like smashing your bones.
Yeah.
And then
the gravitational force going through your body when you jump or have that is so much higher.
Yeah, and because that's like then, regenerating like your bones and then like your muscles and then like lifting heavy. So, but like I said, but it's that slow process. And that's why it might be something like maybe they are starting with like Pilates, where it's like body weight to like, progress that physical health, and then they kind of take it from there. So, like I said, I'm definitely not an expert. I'm still on my journey, like on my own. But then,
That's why we tag on to other people.
Yeah.
We have our area of expertise and we work with the client. That client will do better being referred to somebody else who's an expert in that area, get the support they need, come back, or go out to someone else, rather than trying to be like, oh, kind of look at this, maybe follow this. Just be like, cool, head over there, off we go, learn what you can, come back, then you'll be much better off.
Exactly.
Yeah. I mean, the investment in the health is probably the biggest challenge underlying all of this.
Yeah.
But in the long run, it is so worth it.
Yeah.
And I think every woman deserves to have that care in their life.
And I think we are a little bit lucky in Australia, I guess. We can do a lot of outdoor exercise as well. I think people get fixated
There
on
are
the gym.
opportunities, yeah.
Yeah, we have amazing weather. We have amazing setups around the place where you can start going outside and doing things. And even if it's things like just going for a simple walk after dinner, that helps to regulate your blood sugar and insulin levels. So that it's just, I don't want to say simple, but it doesn't have to be expensive.
Low barrier steps as well.
Yeah, weighted vests, all that type of that type. What Kmart, like $15, $20. Kmart, give us some freebies. But things
The
like
less
that.
excuses and the easier you can fit it into your routine, the more likely you're going to stick with it. And we all know it's consistency at the end of the day.
Yeah.
I think we've covered a massive amount of information today, which is awesome. It's always the case when you come in. There's so much information that you have, which is great. So if somebody who's listening wants to come and get some advice or help from you, or can find you online, where can they go?
So the website is Yoni Health Clinic, and that's also Instagram and Facebook. So you can either reach out. The Instagram and the Facebook have the link to the website. So ideally, you can book in for your initial consultation. We can do face-to-face or telehealth. I'm so happy to see anyone across Australia via telehealth. And then, we can take it from there. Or if you prefer face-to-face and you can't travel, I'm more than happy if you want to reach out, and I can look at other clinics that I know specialise in this area, and happy to send you information for you to, go to those clinics as well with colleagues.
And if you are not into the menopause yet, but want to hear all about hormones, we will link to a previous episode in the show notes as well. So you've got so much with you already.
Yeah. And like I said,
So
I'm happy. Like I said, it's I guess the hormones. It's not just perimenopause, menopause. I also see clients, pre-fertility, period issues, and like I said, seeing partners and males as well. So everyone is welcome.
There is so much help available. So as long as we know about it, we can share it around and
definitely
give people the support that they need.
Yay!
So good to have you on again. Thank you so much for coming in.
Thank you for having me again.
Thanks so much for listening. Subscribe to hear more and stay updated when we release a new episode, but we'd also love it if you wrote a review if this episode has resonated with you. Remember that nothing changes if nothing changes, so reflect on what you've learnt from this episode, and we would love it if you message us your key takeaway. Until next time, keep showing up for yourself, take action for your health, and remember that you are powerful. Thank you so much. That was amazing.